والصلاة والسلام عليك يا رسول الله. دكتور محمد الشهاري، استشاري جراحة عامة وجراحة مناظير، استاذ مساعد كلية الطب جامعة صنعاء، عضو جمعية الجراحين الدولية، عضو جمعية جراحة الكبد والبنكرياس والقنوات المرارية. Today we will speak about an important topic. It is the neck masses, especially in adult. It's a common topic that we may face in our OBD. But generally, neck masses should be classified into main categories: either cervical neck masses, cervical lymphadenopathy, or non-cervical lymphadenopathy. Today we will speak about the cervical lymphadenopathy, and inshallah in other topic we will speak about the other differential diagnosis for the cervical lymphadenopathy. So, cervical lymphadenopathy is considered to be an important topic, should be described and should be analyzed, and we should know what's the approach for the cervical lymphadenopathy. Why? Because in adult mainly, cervical lymphadenopathy, non-thyroid cervical masses considered to be about 80% considered to be a malignant. More than 80% should be considered to be a metastatic, and more than 80% of the metastatic should be considered to be an squamous cell carcinoma. Now, once we receive a patient with cervical lymphadenopathy, how we can approach for the diagnosis? What could be this cervical lymphadenopathy? Is it inflammatory? Is it neoplastic? This neoplastic, is it primary like a lymphoma, or secondary for metastasis? And if it's secondary, from where the source? So now we have a patient, adult patient, presented to the OBD with cervical lymphadenopathy. Why we say adult? The children usually, most of the masses are inflammatory, and it is easily to be diagnosed and managed generally. But in adult, as we think, or as we said, the cervical lymphadenopathy, we should think about the malignancy as the main problem, and so we should do a proper approach for this patient. But inflammatory cervical lymphadenopathy should be considered as one of the differential diagnoses in adult, but the malignant point or the malignant side should be considered in our mind. So we should think about malignancy in a patient with cervical lymphadenopathy, especially in those more than 40 years old. Now, I received a patient with a cervical lymphadenopathy. How can I approach? First, try to exclude the inflammatory cause. Then, if it's excluded, think about malignancy. How we can think, is it inflammatory or no? If the patient developed cervical lymphadenopathy within a short period, few days, and he has a history of upper respiratory tract infection, or dental infection, or trauma, or contact with animals, not in our country, because our country, the contact with animals is considered to be one of the habits general, but if we are in the Western countries, the recent contact with animals can be one of the differential diagnoses for cervical lymphadenopathy. But if I received this patient, and during the history, when you started to feel this lymph node, he said within few days, and this lymph node is painful, and the patient has fever, tachycardia, systemic inflammatory response manifestation, and during my evaluation or examination, I noticed that this lymph node lymph nodes are tender, with signs of inflammation like change of the skin, for example, redness and hotness. So I should think about the inflammatory condition, I mean bacterial cervical lymphadenopathy. We can say lymphadenitis. In this situation, I should ask for what's called CBC, C-reactive protein, sometimes ESR, and work up for cytomegalovirus or Epstein-Barr virus, especially for the cytomegalovirus and Epstein-Barr virus if the patient has multiple bilateral cervical lymphadenopathy. So first, I should exclude the inflammatory conditions. If the inflammatory conditions confirmed, I should start the management with the proper antibiotic. For example, an augmentin, some authors said clindamycin, and I should follow the patient within 2 weeks. If the condition subsided, it's okay. I mean, the swelling subsided and the inflammatory condition subsided, it's okay. I should follow the patient within next 2 to 4 weeks. If there is no recurrent for the condition, so it is inflammatory and it's okay. But if the condition not subsided or partially subsided, or there is recurrence for the cervical lymphadenopathy, I should think about the malignant condition. So, first approach. I received the patient with cervical lymphadenopathy. First, I have to exclude inflammatory condition, as I mentioned. If the patient has history of upper respiratory tract infection, dental infection, history of trauma, and he has cervical lymphadenitis or cervical lymphadenopathy within short period to a few days, and he has systemic inflammatory response in the form of fever, tachycardia, I should do some workup regarding the confirming of the inflammatory condition in the form CBC, C-reactive protein, ESR, and I say the cytomegalovirus and the Epstein-Barr virus workup or serological workup only for the condition with the bilateral and multiple lymphadenopathy. Then I will start the management with the proper antibiotic, as I say, the augmentin or clindamycin. This is as the update for this management. If the patient improved, okay, I should follow him within 2 weeks to 4 weeks. If there is no any recurrence, it's okay, inflammatory. But if there is no response, if there is relapse, if there is partial response, I should think about malignancy. Now, I have a suspicion of malignancy. How can I should start? Malignant condition or malignant cervical lymphadenopathy. What's my approach? The approach, first, as we know, cervical lymph node enlargement or lymphadenopathy is considered to be a common problem in adult. I should take a proper history and do a proper examination to evaluate what could be the source of this malignancy. And I should take a proper history to confirm my diagnosis. Now, if I receive patient, some will say, when you will think this could be a malignant condition. First, if there is no any manifestation of inflammatory condition, as we mentioned before, this is first. Second, if the patient is an adult, or we can say old age, or we can say exactly more than 40 years old, the risk of malignancy is high. Third, if we have a history of neck radiation. Fourth, if we have a history of previous cancer involving the head or the neck or the scalp or the skin involving the head or the neck. And if the patient presented with the history of smoking, if the patient has neck swelling for more than 2 weeks and this swelling is painless and it's significant, for example, more than 1.5 centimeter is considered to be significant cervical lymphadenopathy, I should think about malignant condition till proof otherwise. So, in this situation, I should ask what could be the source. Is it primary or secondary? I will ask the patient some questions to reach what could be the primary sites. Is it from the oral cavity? Is it from the larynx, esophagus, breast, chest, nasopharynx? A lot of hidden areas could be the primary source for the cervical malignant lymphadenopathy. So now, inflammatory condition is excluded. I have a suspicion of malignant cervical lymphadenopathy. Why suspicion? Patient is a smoker, more than 40 years old, previous history of radiation, previous history of malignancy, especially in the head and the neck, and the patient has suspicious skin lesion, for example, in the face or in the scalp or in the neck, and the patient an old age, as we said, so I should make a consideration of malignancy, especially if he has a painless swelling and more than 1.5 centimeter or more. The history, I should ask about if there is any oral ulcer, if there is any epistaxis. So think about the face. We have the oral cavity. If there is an oral ulcer or tongue ulcer, if we have an epistaxis, if we have an otalgia, or if we have an history of a change, recent change in the voice, history of odonophagia or dysphagia, for example, mainly, if we have a history of cough, hemoptysis, dyspnea, if we have a history of epigastric pain and early satiety, sometimes gastric cancer we presented with, later on with the metastasis to the neck, we can say Virchow's lymph node. And if we have history of breast lesion, history of thyroid swelling, history of salivary gland swelling, I should ask, I should look for the source of the swelling. And according to that, I will make a correlation between the primary source and the metastatic lymph node. But sometimes the patient will present with the cervical lymphadenopathy without evidence of primary source. How can I evaluate? I asked the patient, he said, nothing from these conditions or symptoms that you ask, I feel nothing. There's no hoarseness of voice, no epistaxis, no change in the weight, and no dysphagia, no hoarseness of voice, no breast mass, there is no thyroid swelling, and no cough, nothing. So how we can approach? First, I will send the patient for chest X-ray, CBC, ESR, and neck CT scan with IV contrast. Why? Chest X-ray because one of the most common site for the metastasis to the neck is the respiratory tract, or we can say the lung. So chest X-ray, which can give us a clue regarding the lung and the mediastinum, if there is enlarged mediastinum. So we can get clue, this one. CBC, it gives us a differential regarding the cell count, could be lymphoma if there is, or lymphocytosis if there is suspicion of viral infection. Neck CT scan with IV contrast. Why? To evaluate what are the lymph node enlarged, group of the lymph node enlarged, and if there is any primary lesion within the head and the neck can be evaluated by the CT scan. And the most important point is to send the patient for fine needle aspiration under ultrasound guidance, and this is one of the most important and diagnostic modalities for cervical lymphadenopathy. Now, after collecting the data, chest CT scan, neck CT scan, chest X-ray, and the fine needle aspiration. The fine needle aspiration, it gives us the following data. Either non-diagnostic. If non-diagnostic, there is no enough cellularity for the evaluation, I should repeat the fine needle aspiration. If the fine needle aspiration for the second time is non-diagnostic, I should take an excisional or incisional biopsy or core needle biopsy. Why? It will be more informative and more diagnostic. So we have two chances for fine needle aspiration. The third one, it will be an open biopsy or core needle biopsy. So finally, the result, either it will be squamous cell carcinoma, it will be an adenocarcinoma, could be melanoma or papillary thyroid carcinoma, or metastatic from salivary gland. How we can approach for this patient? Now the result in front of me, fine needle aspiration, breast and squamous cell carcinoma. What's the next step for this? Squamous cell carcinoma, so I should look for what could be the primary site for this metastatic lymph node. Patient, after evaluation by CT scan for the neck with IV contrast, it may give me clue. There is thickening in the nasopharynx. There is thickening involving the hypopharynx. Why these areas? Because this area are lined by squamous cell carcinoma. If the CT scan is negative, I should send the patient for what's called pan endoscopy. What is pan endoscopy? Ban endoscopy, that's mean I should do nasoscope and endoscope for the hypopharynx, nasopharynx, for the upper esophagus. Why upper esophagus? Or we can say for the esophagus, because the lower part of the esophagus is lined by adenocarcinoma. And could be I have to send the patient for bronchoscopy to evaluate what's the primary site. If the primary site is identified, and according to the primary site, I will manage. If there is in the nasopharynx, hypopharynx, may I refer the patient for the ENT to do the proper staging? Is it resectable, not resectable, for radiotherapy, whatever. But regarding the cervical lymph node, the patient should undergo what's called modified radical neck dissection to remove the involved lymph node group, and to send the patient for what's called oncological evaluation or management regarding radiotherapy plus minus chemotherapy. So this is the approach after confirming the diagnosis by fine needle aspiration. It is squamous cell carcinoma. I will look for the primary site. What is the primary site for squamous cell carcinoma? I will evaluate the region that could be the primary site by what's called pan endoscopy, bronchoscope, esophagoscope, nasoscope, and for the oral cavity to evaluate what's the primary site. According to that, we will manage. Sometimes could be the tongue, sometimes nasopharynx, hidden area, piriform fossa, whatever. So if the result came of what's called an adenocarcinoma from the cervical lymph node, little bit, it's a problem. Why? Adenocarcinoma, that's mean we have a primary site has lined by the cells, can give us a metastasis and causing what's called an adenocarcinoma. Could be the breast, could be the stomach, and could be, for example, the colon, which is rare, but could be. So I have to send the patient for abdominal CT scan, pelvic CT scan, chest CT scan. I should look what is the primary source for this. And I have to send the patient for mammography for those more than 40 years old. And breast ultrasound could be the primary source. Why adenocarcinoma is a little bit a catastrophe for the patient? Because this lesion, or if we found the primary site and the patient has metastatic cervical lymphadenopathy, it is considered to be stage 4 cancer. Stage 4 cancer, so the patient should be shifted for oncological management by oncologist in the form of chemotherapy, radiotherapy, whatever, for down staging. Then later on, maybe we need surgical intervention. But the problem, if we didn't get or catch the primary site, what we can do? So the patient is a candidate for what's called neck dissection, because the primary site, we cannot evaluate it, we cannot reach it after CT scan, positron imaging tomography. Sometimes it's rare condition, but if we face the patient for neck dissection. If we face a patient with fine needle aspiration and the result is metastatic tumor from the thyroid gland, little bit is favorable prognosis in comparison to the other. The patient's candidate for total thyroidectomy with neck dissection for the involved group, and later on isotope scanning to evaluate what could be the other site involved by the metastasis, and the patient may need isotope scanning and radioactive ablation. But if the result melanoma, it's bad prognosis a little bit. Why? Because melanoma is an aggressive tumor. But we should look what's the primary site, and according to the depth of the melanoma and the involved lymph node, it's need multidisciplinary team by the oncologist, and we may need the surgeon to do excision for the primary site and modified neck dissection for the involved group. So the idea, cervical lymph node is a common problem that we face. The problem is a lot of patients, we face them they receive just an antibiotic without proper evaluation. The main point that I need to give or to focus is think about malignancy in an adult patient, especially those old age with history of smoking and those presented with the lymph node painless more than 1.5 centimeter. You should send the patient for neck CT scan, chest X-ray, and fine needle aspiration. According to the result of fine needle aspiration, you will start the further management. The fine needle aspiration is the cornerstone in the evaluation. You have 2 chances as a guidelines for the evaluation. If the second chance or the second fine needle aspiration not informative, you should do an open biopsy. The category or the possible result for fine needle aspiration that we didn't mention could be lymphoma. If there's suspicion of lymphoma, we should do an open biopsy. Why? Because lymphoma need to be confirmed by open biopsy. This first, we need adequate tissue for evaluation. Second, we need to evaluate what could be the lymphoma. Is it Hodgkin lymphoma, non-Hodgkin lymphoma? What could be the type of lymphoma? Nodular sclerosing, lymphoproliferative. Each one has its prognosis and its special management. Generally, there is an approach what's called CHOP, cyclophosphamide and so on from the drugs regarding the lymphoma, but the prognosis is different from each type. So this is the main points that we should consider regarding the cervical lymphadenopathy. If you receive the patient with cervical mass, is it lymph node or non-lymph node? If lymph node, try to get this minimal approach or general approach regarding the cervical lymphadenopathy. Exclude inflammatory condition, then evaluate if it is malignant or no. The main or the cornerstone for evaluation is the fine needle aspiration, and it will give us a clue for the diagnosis, then for the staging and management later on by the proper radiological investigation and proper examination. I hope to get the benefit from this. Inshallah, if we have a chance to speak about the non-lymphadenopathy cervical masses, how to evaluate and how to approach and manage. Thank you very much.